All right, good afternoon, everybody. Welcome once again. The recording has now begun, and welcome to the December meeting of the Universal Healthcare Commission. I will turn it over to Vicki, who can call the meeting to order.
Welcome, Commission members. It's now 2:01, and I call the December 11th meeting of the Universal Health Care Commission to order. I will begin by giving a land acknowledgement. I would like to encourage other commission members to provide land acknowledgements in the future, and I'm happy to help them if they're interested in that. I think especially today and this week when we're having all this weather, it's important to remember that the land that we all live on is Indigenous land, that the right here at the Healthcare Authority, we're on the land of the Nisqually and the Squaxin Island tribes and coastal Salish people. And that most importantly, that the loss of that land, the removal of people from their ancestral lands, the loss of culture, the children who were stolen to boarding schools, has had an impact on the health of Indigenous people in Washington State and across the United States and really the world. And that as we do this work, it's important that we keep in mind that those things that have happened in the past have real world consequences in our present, and that when we work to improve healthcare, that we need to keep in mind that those traumas need to be addressed as well. So thank you. Let's give a warm welcome to everybody who is able to join us today for the commission meeting. We want a warm welcome back to Omar Santana Gomez from the Office of Equity, who's been out, but he's joining us today. As you know, we have some vacant seats on the commission. 2 of the vacant seats are governor appointed, and 1 is a member of the Senate. HCH staff has been reaching out to the governor's office and the legislature about appointments to those positions so that we can have a full commission. Mary, would you like to take roll call?
Sure. Thanks, Vicki. I see people are coming in as we take the roll call. We might have to go through the roll twice. When I say your name, please unmute yourself and let us know that you're here. Joan Altman.
I'm here. Hi, all.
Hi, Joan. Jane Beyer. Jane? Okay, we can circle back. Senator Annette Cleveland.
She told me she couldn't make it today.
Okay.
She had a conflict.
Thank you. Nicole Gomez.
Hey, everyone.
Thank you. Next on the list is Dave Eisminger, and he let us know that he is unable to attend today. Dr. Kwanget.
I am here, but apologies that I have to leave at 3 today for a conflict.
Thank you. Vidisha.
Hi, I'm here.
Okay. Representative Parsley.
I'm here.
And Omar.
I am here. Thank you.
Thank you. Representative Schmick.
Yes.
Okay. And Mohammed.
Yes, I'm here. Hi, everybody.
Thank you. And I'm taking one more look for Jane. I don't think Jane is here. If you are, please speak up. Okay. Back to you.
Thank you. Now we will vote on approval of the October meeting minutes. They were in your packet. Is there any discussion or proposed changes to the meeting minutes?
Joe Schmick here. I move to accept the minutes as presented.
Thank you, Representative Schmick. We have a motion.
Second.
Thank you, Representative Parsley. We have a motion and a second. All those in favor say aye. Aye.
Aye.
Is any opposed? Say nay. All right, motion approved. We'll move on to public comment. Since our last meeting, we received a number of public comments. Those comments have been included. Those comments include support of our mission and encouragement to keep working towards our goals. There were suggestions for transitional solutions to be considered by the commission. There were comments about changing the state's working relationship with insurance carriers and bringing more administrative function in-house. And commission members received these public comments as part of the full meeting packet for review. Individuals may also provide public comment during the meeting, and we will hear from them now. For those online, please use your Zoom feature to raise your hand. You will be moved from an attendee to a panelist. As Mary said earlier, please, you have to click on your computer and accept that to get moved over. There's like a little lag, so just be patient and you'll get moved over. When we call on you, please state your name and your affiliation. If you have one before speaking, we have a large number of people signed up for public comment, so we're going to go with 90 seconds or a minute and a half with time. And again, just a reminder, if you don't get to say everything you need to say, please send us written public comments. Mary, would you please start with the people who've signed up?
Thank you, Vicki. And just to be superficial with the role, I did not call your name. Are we supposed to call you and enter that in? Vicki Lowe.
Present.
Apologies, everyone, for doing that after the fact. And yes, as Vicki mentioned, we have a lot of interest this time, so we're going to be sticklers about the minute and a half. And our first speaker who signed up, we're going to first go with the people who signed up ahead of time, and then if we have time, other folks can raise their hand to make a comment. Christine Anderson.
Hello. My name is Chris Anderson from Redmond. Like many workers this year, we've had a change in income due to a layoff. When we reported this on the Washington Health Plan Finder last week, to my surprise, our current plan was terminated immediately. I chose one of the Apple Health options and spent 2 hours on the phone with them while they tried to find a PCP who accepts their plan. Being a doctor listed in their directory doesn't mean they actually take that insurance. Both my husband and I have been waiting months for separate procedures that were finally scheduled, and now that our previous policy has been terminated, we don't know if they'll be covered. Time has been spent and wasted getting referrals and pre-authorizations that mean nothing now. And it may not even be possible to find a plan that both his specialist and my specialist accepts, but our entire family has to be on the same plan. Our experience is not unusual. We need a system that provides comprehensive coverage and access. We need to know we can see any doctor we need to and not have to worry about which insurance plan they accept. I urge the Commission to make progress toward making universal health care a reality for our state. Thank you.
Thank you for your comments. The next person we have who signed up ahead of time is Raleigh Watts.
Unmute. Okay. Hey, commissioners and Chair Lowe, thank you so much for your work. We are in an emergency, and as commissioners, I know you hold that truth in your heart. In that context, imagine this headline. Commission finds billions to pay for healthcare. You can make that headline a reality. Today, during the presentation on healthcare costs, on slide 51, you'll see that $2.9 billion of our annual healthcare costs are spent on NCPHI, that is, net cost of private health insurance. It's the part of our total cost that goes to private corporations for advertising, for sales commissions, for profits, for shareholders, and other corporate costs. That's $2.9 billion not spent on healthcare or healthcare management. Please ask the presenter today for more information about that $2.9 billion NCPHI. How much of it is associated with state programs? That's the low-hanging fruit that the Commission can change. How much is associated with state programs? And second, please ask yourself, what value do these costs bring to the healthcare system, to patients, to enrollees, or to governments? What value do we derive? That $3 billion could buy a lot of care for a lot of people. Thank you.
Thank you, Raleigh, for your comments. The next person we have is Sherry McAvoy. Oh, and we should also add, please state your name and your affiliation if you have any. Thank you.
See Sherry.
Sherry, no, Sherry not here? Is Sherry, oh, what were you about to say?
Trying to promote Sherry.
Okay.
Sherry declined.
Okay. You know, we will jump ahead and Sherry, we will come back to you when you see the panelist link and it says John V. panelist, please accept. The next person may or may not be able to attend today. She let us know ahead of time that she had a conflict. Kasara Key.
Don't see that that name.
Okay. Amanda Halverson. Amanda's here with her hand up.
Hi, I'm Amanda. I volunteer with Whole Washington, and I've lived in the greater Seattle area my whole life. I'm a freelancer, so I purchase insurance through the Washington Health Plan Finder. Even with coverage, I often have to pay hundreds of dollars anyways for doctor's visits, and sometimes it's more expensive with insurance. Once I had to go to urgent care during the short window I wasn't covered, and I paid $250. A few months later, I went back to urgent care when I had my new plan, and the bill I got was for more than what I paid when I was insuranceless. And it wasn't that my insurance company hadn't covered anything. I got a statement that they had, in fact, covered about $400. I should not be paying more for the same service when I have insurance that I'm paying hundreds of dollars for every month. In a time when costs are up across the board and people are losing their insurance thanks to federal subsidies and tax credits not being extended, we need universal health care now. We have the chance to do something incredible here. We can be the first state to have universal health care. The people support it, and it makes financial sense to go single payer. I urge the Commission to provide a solid plan to our state legislators for making universal health care happen now in Washington state. Thank you.
Thank you. Let us go back to Sherry. Sherry, if you get the panelist invitation, please accept it, and then you'll be able to make your comment.
Oh, I was just unmuted. Were you looking for me to speak?
I'm sorry? Sherry and then Michelle. There you are, Sherry. If you unmute yourself, we should be able to hear you.
Okay, hi. My name's David Webb. I'm a resident of Olympia. Are you able to hear me?
Yes.
Okay. I'm here today to speak in support of universal health care. I think that this was incredibly important for people. The biggest reason that people stay in dangerous domestic situations or abusive workplaces is because they need, well, not the biggest, but one of the biggest reasons is that they need healthcare that is provided through our systems that are driven by capitalistic values. We need to support everyone's health, whether or not they are able to work. People deserve to survive and receive adequate healthcare. I'm formerly from Massachusetts, and when considered where to move in the country, Washington is one of the limited options that has any level of state insurance would be beneficial to me. I think Washington is already progressive. It could be way, way, way better. This is a step in the right direction, and in saying that Washington cares about its residents in an important way, it's an opportunity to set a national example as when health is at work more in politics at a rural level.
Thank you, David. And Sherry, I think you are a panelist, if you'd like to add your comment.
It goes through, and
Oh.
I really, really hope you guys can do it. So thank you so, so much. Again, my name is David Webb, and I'm from Olympia, Washington.
Thank you. Sherry, would you like to begin?
Yes. Can you hear me?
Yep.
Great.
You did it.
My name is Sherry McAvoy. I'm a nurse practitioner from Spokane, and I volunteer with Healthcare for All Washington and Whole Washington. And I support single payer healthcare because I've seen the destruction of patient care with the unnecessary abuses and layers of bureaucracy that the private insurers have lobbied for and won. I used to spend the majority of my day in direct patient care. By the time I retired this year, I was spending 30 to 40% of my day charting, coordinating pre-authorizations, navigating pharmacies, and imaging denials related to insurance denials, and to pay and researching resources where my patients could get the care that they needed and deserved. There's no bigger emergency in Washington state than to pass a single payer universal health care bill. And I insist that you lobby for and get Medicaid deprivatized and make 2026 the year we get single payer universal health care in Washington state. Healthcare for All Washington, Whole Washington, and one payer states have all the legal legislative help you need to accomplish this goal. Thank you very much for listening in.
Thank you. Now we had Michelle Sharlock had signed up ahead of time. I don't see Michelle here in the list of folks, so we're going to jump ahead and we can circle back and see if Michelle's able to join us. We have Rhonda Gilligan.
Hello, my name is Rhonda Gilligan. I'm from Redmond, and I'm a volunteer with Whole Washington. I'm a bit unusual among the people who are working to bring universal health care to our state in that I'm one of the lucky ones. Thanks to my career in tech, I've almost always had good insurance, and at times I had great coverage. I've never gone without needed care or had to choose between health care or food for me or my family. And when I got laid off from my last job and made the choice to retire, I got Medicare, which covers my needs affordably. I'm lucky. I'm guessing most of you on the panel are among the lucky too. But what fuels my efforts on behalf of state-based universal health care is that it simply shouldn't have to come down to luck as to who gets care and who doesn't. Healthcare should not be a commodity reserved for the lucky. And as bad as things are, they're about to get a lot worse. Luck could be running out for all of us. We are out of time for you to be sitting here. How many more of the unlucky have to die or go bankrupt due to medical debt before we act? This cannot go on. I'm sorry, it's simply wrong. We have an answer. We have a way forward out of this crisis. We've had it for 4 years. We have a way to help all Washingtonians, and we need to act now. You need to act now. Time's up.
Thank you very much. We have on the list Demian Godin, but I do not see that name among the people who are logged in. So we will jump ahead and come back, and we will go to Layla, who I think has been promoted to a panelist.
Yes, thank you. My name is Layla Saliba. I'm here just as a regular person. I have a bachelor in nursing. I've worked as a registered nurse for about 10 years, and I do hold a degree in public health. And we learned about social determinants of health, which include things like stable housing, food security, and more relative to this hearing, access to healthcare. Universal healthcare is an upstream intervention. So this is about investing our dollars in prevention and equity. Broader health coverage is linked with improved population health because it allows people to access necessary care early and consistently rather than waiting until conditions become emergencies. There's a number of studies proving this on everything from PubMed to we just know that this is true. It's cost effective. As we know, the United States spends more per person on healthcare than any other wealthy country, yet we have so many uninsured. So universal single payer system would reduce the national health. This would obviously scale for Washington. So this would reduce our health costs at the state. So proposals to cover every resident would remove redundant administrative costs that we experience in the state and profit incentives in our current fragmented system. It would help fix those. So universal healthcare isn't just a moral imperative, it's evidence-based public health policy, and it aligns our dollars with outcomes. I urge you to support healthcare as a right for all Washingtonians. Thank you.
Thank you. The next person who had signed up is Derek Dexheimer, and I don't. Oh, is that D Dex in the list? We can promote you. One moment. Accept this link, please. Oops, I did the wrong one. Sorry. This is why they don't usually let me do this.
I think something happened that shouldn't have happened. Should I sign out and?
Is this Derek? Is this Derek?
Yes, that's me.
Yes, please. Now you are able to speak.
All right, thank you. I am just some person on member of the public who's signed up for the whole Washington advocacy group. I don't know why this is taking so long, why this is such a question. Millions of people are about to lose their health care as it's become unaffordable from the Trump administration. This is going to kill people and impoverish people. Like a previous speaker, I have had private health care for most of my life. It did not provide very much value for the amount of money I put into it. Due to financial circumstances, I now qualify for Apple Care, Medicaid, and it saved me from financial ruin when I had a stroke last year. Everyone should have this. There is no reason why we shouldn't have this. It's all written down. Dr. Hisao, I think his name is, who designed the healthcare program for Taiwan, which was back in the late 80s and early 90s. So it's been going for 35 years now. 99% coverage, 99% approval from the public. There's no reason why we can't have this. You are killing people by not having single-payer healthcare, which we desperately need. I don't understand what the holdup is. Please stop turkeying around and get this to us. Thank you.
Thank you. The next person who had signed up is Marcia Stedman. Is Marcia here?
Yes.
Oh, hello, Marcia.
Thank you. So, my name is Marcia Stedman. Thank you for this opportunity. I'm a past president of Healthcare for All Washington and a current board member. The chart on page 52 of today's meeting materials compares the Medicaid spending growth rate in 6 states. In 2023, Washington's rate of growth was the second lowest at approximately 5.5%. But Connecticut's growth rate was even lower, 2.5%. How did they do it? By eliminating managed care organizations, MCOs, from administering their Medicaid program. Other states could do the same. Please read our letter starting on page 22 of today's meeting materials for a summary of the research cited in the PNHP report titled Removing the Middlemen from Medicaid. MCOs do not meaningfully coordinate the delivery of care. MCO overhead is estimated to be 13%. At 10 to 17% of overhead would be the savings from deprivatizing Medicaid. The project Washington is projected to save between 757 million and 1.28 billion dollars. We already have the infrastructure to manage our age disabled and dual eligible clients that are not under the MCO contracts. This could be expanded and enhanced with primary care coordination to provide an operational foundation for deprivatization. In addition to saving millions of dollars annually by eliminating MCOs from their Medicaid program, Connecticut also improved physician participation and reduced ER and hospital costs, even in the first year. Thank you.
Thank you. The next person we have who registered ahead of time is Dave Chase.
Thank you. I'm the author of The Opioid Crisis Wake Up Call, and today I want to share a specific no-cost opportunity that addresses both Public America organizations, which I have no affiliation with. Fentanyl dominates the headlines, but the real story began in doctors' offices. 3 out of 4 heroin users first used prescription opioids. It's not just a street drug problem, it's a healthcare system problem we can measure and fix. Here's what it looks like for Washington Medicaid members and state employees. Based on typical data for your 623,000 adult Medicaid covered lives, approximately 73,000 plan members are prescribed opioids annually, creating a $290 million opioid-related cost. When prescribers follow CDC guidelines through targeted case management, this can drop by 75%. That's $220 million in annual savings while protecting our neighbors and employees from dependency. In addition, Washington State employees, that's a whole other opportunity. This model has been deployed in 1,700 health plans across 40 states, achieving over 60% reductions in high-risk prescribing while generating 3 to 5% overall plan savings. And what makes it powerful is the same physicians prescribing state employees and Medicaid recipients treat all Washington residents, so it has a spillover effect. Thank you very much.
Thank you, Dave. We also have signed up to speak Catherine Lewandowski. Catherine, if you are the person who says Catherine Arlington, just put your hand up. I think that's you. She there? Yeah.
Can you hear me now?
Yep. Thank you.
Good. I'm sorry. Thank you, Chair Lowe and members of the commission. For the record, my name is Catherine Lewandowski. I'm a registered nurse from Arlington, Washington, volunteer board vice chair for Whole Washington, and volunteer board treasurer for One Pair States. We all appreciate and thank you all for the work that you do on this commission. While I was preparing for this meeting and reviewing all the written comments that you've received, I was so impressed by the written comments that the commission got in advance of this meeting, and I hope that you are taking the time to read them and take them to heart. They were very impressive. I'd like to share a quote I received from my current professor. Hope is important because it can present the moment less difficult to bear, or it can make the present moment less difficult to bear. If we believe that tomorrow will be better, we can bear a hardship today. And that's by Thich Nhat Hanh, and I'm sorry if I mispronounced that. It reminded me of a senator refusing to give our Washington Health Trust a hearing because they did not want to give anyone false hope. And I remember my oncology days where our head oncologist always reinforced that we do not ever want to take away anyone's hope that there could be a miracle and they could be healed. And I have to agree with him. I often saw that when a patient loses hope, their time to passing comes quickly. So I want to reinforce with you all, worse than giving people false hope is giving them no hope at all. I sometimes feel that this is the message that our legislature and our elected officials have for us, that there's no hope for a different and better tomorrow. And that is just not acceptable to me. Thank you for allowing me to speak, and I fear that here in America, we may not be able to guarantee that right to all persons in the future. Thank you.
Thank you, Catherine. That exhausts the list of the folks who signed up ahead of time, and I just took a quick glance through the list. I'm just going to call out the names of the people just to see if you've joined us. Kasara or Michelle or Demian. I don't think those folks were able to join us today. We have a few hands raised that we think we will go through and try to make up the time, other parts of the agenda today. So the raised hands, we have Sarah Turner.
Great. Hello. My name is Sarah Turner, and I'm from Seattle, and I volunteer with Whole Washington. I urge this commission will work as quickly as possible to make universal health care a reality in Washington. Because last July, I went from a healthy 41-year-old with no major medical issues to clinically dead on my office floor in a matter of minutes due to a complex medical emergency. Doctors didn't expect me to survive my first night in the hospital, but I did, thanks to a host of medical professionals and the health insurance I had through my employer, which made quality medical care accessible and affordable. However, I had to quit my job because I'm unable to work after this medical event, and now my spouse and I have to buy health insurance on the marketplace. Last year, we paid $70 a month through my employer for health insurance in a 2-income household. Next month, we will pay $1,200 a month just for insurance premiums in a now single income household, which is an increase of over 1,600% to our budget. We'll be able to absorb this increase, but it doesn't take much to imagine how a small change in our situation would leave me forced to work before I'm medically ready, homeless, in thousands of dollars of debt, or dead, because I would be unable to pay for the medication that I need to be able to prevent this from happening again. My story is dramatic, but it isn't unique. Universal health care is an immediate need for all Washingtonians to keep our communities healthy, working, and thriving, and I urge you to make this a reality. Thank you.
Thank you. I think we have time for 2 more comments to keep us on track. So we'll go with the next 2 hands. And also, I'd like to note that Senator Cleveland has joined the meeting. So next we have Mark Prue.
Hey, here we go. May I start?
Yes, please.
Oh, okay, great. Thank you very much. My name is Mark Prue, and I live in Des Moines, Washington. I've supported single-payer universal health care for decades, and the way that healthcare has evolved during that time has only strengthened my advocacy. The present healthcare system is predatory. This is not an accident. It is not an unintended consequence. It is by design. The intent of the system is not to promote health and wellness. The intent is to keep people healthy enough to participate as long as they have sufficient disposable income, thereby enriching insurance companies. It is evil dressed in a $2,000 suit backed by a PR system selling the idea that it cares about you. I imagine that this commission finds its task difficult. This is, I suspect, because changing the existing healthcare structure to achieve the outcomes noted in its mission statement will be utterly impossible without enraging powerful forces who like the system just the way it is. To move us toward a more just and humane society, I want the commission to muster the courage to do just that. Tell the legislature to implement single-payer, universal health care legislation as advocated by Whole Washington. Thank you very much.
Thank you. As I said a moment ago, we have time for 1 more comment before we move forward with the agenda. And the next person with a hand up is Elizabeth New.
I just spoke. I just got done.
Hello, I'm Elizabeth New from the Washington Policy Center. A think tank is interested in a free market healthcare system, a system we do not have. Our third-party payer system is hurting us, and this commission is working to create an even stronger third-party payer system in the state. Trading one bad system for another is not the answer. I urge you to recognize the shortcomings that will come with the healthcare system you seek. The pattern of universal taxpayer-financed healthcare is waitlisting and rationing. The kind of healthcare in a universal taxpayer finance systems would not be acceptable to Washingtonians. We need patient-centered healthcare where the decisions made are closer to doctors and patients, not insurance or lawmakers. Healthcare is expensive. Cost increases are not unique to those receiving insurance through the health exchange. They are increasing for employers and workers and other commercial payers as well. Various state policies and regulations are also causing a cost shifting that is unsustainable for providers and commercial payers. More competition, not less, and more payers, not fewer, are key for bringing cost containment and affordable and quality healthcare for all. Thank you.
Thank you. Okay, we have 3 hands up. We are going to do the next 3. Consuelo Echeverria. Okay, we are going to end after the 3 that were there. I don't know if Consuelo is here. Can we go to Lindsay Nickel? Oh, Consuelo, I see that you are there. Please unmute yourself if you'd like to make a comment.
Hello?
Yes, we can hear you.
Hi. It has been a while. Hi, everyone. It's been a minute. I want to tell you a very, very quick story. As some of you might remember, I lived in Istanbul, Turkey for 22 years. This summer, I went back there and I had a medical emergency. I fell and had a major cut on my head. An ambulance came and picked me up. My first question when I got into the ambulance is, oh my God, how much is this going to cost as they're putting IVs in me and doing the antibiotics and wiping the blood off my face? And the woman looks at me and says, you're bleeding all over the place and you're asking about money? I get taken to the emergency ward. I get an MRI. I get an X-ray. I get stitches. I get a tetanus shot. I get follow-up aftercare. When I go to say, well, how much do I owe? Guess what they said? Counsel, guess how much they said. Like, seriously, guess how much they said. It was 0. It was 0. It is absolutely appalling that this commission has been for almost 5 years and we still don't have a bill. Please, it's not that hard. There are many, many, many bills out there from Oregon, from Washington State, from New York State, from Connecticut. Colorado right now is doing a financial analysis on the cost of implementing universal health care. We do not need to reinvent the wheel. It is insane that in 5 years we have nothing.
Thank you. We're going to have 2 more comments, and then we're going to have to wrap up this part of the meeting. Ashley, you can unmute yourself, and then we will have Matt Wright speak.
Mary, I'd already moved over. I think it was Lindsay Nickel.
Oh, I'm sorry, Lindsay. I jumped right over you. Lindsay, please go. Sorry about that.
Oh, that's quite all right. Can you hear me okay?
Yes.
Okay. Hi, my name is Lindsay Nickel, and I am a licensed mental health counselor in Washington. I have a private practice in Gig Harbor, and I've been in the mental health field since 2005. I am also a new volunteer with Whole Washington. The topic of healthcare is broad, so I'm going to center my comments today on the need to remove private equity firms and for-profit corporations from the healthcare delivery network in the state. As you know, for-profit corporations and private equity firms such as Blackstone, which owns Team Health, a provider of ER physicians to Washington hospitals, are solely interested in maximizing profits for their shareholders, not delivering timely, equitable, or affordable healthcare for consumers. Although consumers are an important part of their profit-producing chain, we are not the primary benefactors of these services. This creates healthcare disparities, provider deserts, and skyrocketing costs that outpace inflation and common sense. And it shouldn't be that in the richest country in the history of the world, that Washingtonians have to hustle for the healthcare scraps left behind after the suits push back from the table. There are lots of ways to make money in Washington state, but healthcare should not be one of them. So I urge the commission to provide a solid plan to make universal healthcare happen for all Washingtonians, and I appreciate your work so far. Thank you very much.
Thank you. So we will go to Ashley and then to Matt Wright. Ashley, I think you are able to unmute yourself.
I haven't signed up to speak or anything.
Okay, then why, if you don't care to make a comment, we can go to Matt Wright. Matt, you should be able to unmute yourself.
And I am. Thank you so much for reminding me about that part. Thank you, Chair Lowe and members of the commission. My name is Matt Wright. I'm a voter in the 43rd Legislative District, a volunteer with Whole Washington, and a lifelong resident of Washington State. My experience with healthcare in Washington has taught me a lot about where the current system struggles. In 2001, I was kicked off of Washington Basic Health and asked to refund subsidies the same week my wife and I learned that we were pregnant with our first child. For months afterwards, I paid for our health insurance out of pocket while also paying off the debt Washington State extracted from me for not correctly reporting changes in income that, as a freelance worker in commercial film production, fluctuated wildly from week to week. Over the years since, I've had various employer-based healthcare plans and have been through the stress of losing those plans because of mass layoffs in 2007 and 2021. Currently, I'm back to freelancing and dependent on my wife's employer plan. She is working fewer hours because of a chronic health condition and recently received her first paycheck for $0 because all of her pay went to cover insurance premiums. We expect that she'll actually have to pay her employer to cover premiums before the end of the year. Our story is just one of millions, and I'm fortunate enough to have resources many do not. For many, similar setbacks result in bankruptcy, food insecurity, homelessness, and death. But there is good news here. The solution to this problem is obvious. Every study shows that single-payer healthcare provides better medical outcomes, is better for the economy, and contributes to good governance. Every poll shows that likely voters across the political spectrum want single-payer healthcare, even if it costs them more in taxes. While it's important to collect data and build recommendations on the evidence, we have the evidence we need, and we've had it for years. On a day when 2 plans to extend ACA subsidies have failed to pass at the federal level, continuing to investigate the merits of single-payer healthcare feels like measuring for drapes when the house is on fire. Believe it or not, there's more good news
Matt,
here.
I apologize, but we've hit the minute and 30-second time limit. If you could wrap up your comment, please.
Sure thing. In an incredibly short 2026 legislative session, we need all the help we can muster to make sure House Bill 1445 and Senate Bill 5233 get a real hearing. I urge the commission to champion these bills and to recommend that they be presented to the House and Senate for consideration. I urge the commission to develop a 2026 working plan focused on delivering universal health care for Washington State. It's within reach, and your recommendation will go a long way towards getting us here. Thanks for considering.
Thank you.
Thank you, Matt, and apologies for having to cut that off. If there was anyone that had additional comments, please feel free to submit written comments as well, and we can include that in the next meeting packet. Thank you.
All right. And thank you, everyone, for your comments. As a reminder, the commission welcomes and encourages public comment and appreciates all the feedback we receive. Public comment is an important part of this process as it provides an opportunity for the public to have their voice heard in regular meetings. Public comments can be provided orally during the meeting or in written form at any time to the commission's inbox. HCA, did you just put it in the chat?
I just put
Which
it in
is
the
in
chat.
the chat, but it's HCA Universal HCC at hca.wa.gov. Oral public comments are not accepted outside of the public comment period. Commission members review and consider all public comments received, but generally will not respond to public comment. And I know we've had feedback on this, and it's awkward. It's awkward for us too. If the commission deems it appropriate, a response will be provided in writing or at the next public meeting. All right, if we can move on to tab 3 in your meeting books, we'll hear report outs from our commission members. And I know some aren't here, but okay, we welcome commission members to share updates that might align with the commission's work. And we'll start with Joan Altman from the Washington Health Benefit Exchange. Joan, do you have any updates to share?
Hi, everyone. Sure. Yeah, Joan Altman, Director of Coverage Expansion and Strategies at the Exchange. Vicki, I agree with you. It is, I do appreciate hearing from people. It is awkward sometimes to not be responding or have more conversation at the beginning of these meetings, but I did want to thank everyone who's submitted public comment. I read them, we read them, and there's often really helpful examples and anecdotes in there that I can bring back and share with people in my circles, particularly people's personal experiences interacting with their healthcare system. So really appreciate people taking the time to write them. I will say from the Washington Health Benefit Exchange perspective, a few things I think are relevant. Several of you mentioned the ongoing federal dialogue around potential expansion of the federal tax credits. I think we're preparing for those to expire, which will bring financial hardship to many people. We've already implemented federal requirements that took away premium tax credits for some of our lowest income customers, people under 100% of the federal poverty level. Are losing their tax credits for 26, so they're facing those increases now. And then we have the continued sort of elimination of the enhanced federal subsidies, and then more loss of federal subsidies coming in the future. Notably in 2027, there's an additional 15,000 people who will lose federal tax credits. So we know that federal tax credits in combination with our state subsidy have really helped people afford coverage as premium costs have increased. Definitely the stories about people facing increased premiums this year and tough choices have really resonated. We are in open enrollment, so anyone who signs up for healthcare through the exchange before the 15th of this month can get coverage starting the first of the year. I will say the impact on our customers is really varied. It varies broadly based on whether you qualify for those federal tax subsidies or not. And we are seeing a lot of increased traffic, and we are seeing fewer new customers, and we are seeing a higher cancellation rate. So sort of to echo the public comments that were made, we are in a very challenging time, and a time that we expect to become more challenging. Looking ahead to legislative session, the exchange is pursuing some asks related to our state subsidy program. We have no state subsidy funding after this year. Have requested additional funding and funding to sustain state subsidy efforts in light particularly of federal kind of reductions. We're also looking at increased exchange board authority that would help address some of the access and affordability concerns that have already been noted. We have some counties that are at risk of going bare, to the comments earlier about plans being canceled and terminated. We do have a few counties where we want to make sure there's still adequate coverage, and we are seeing affordability challenges kind of across the market. And then looking ahead to federal changes, in addition to the change I mentioned with lawfully present people who are going to be losing tax subsidies. We're also looking at changes related to potentially a shortened open enrollment period, increased verification work, people getting kicked off Medicaid. So really working on mitigation strategies there. The legislature gave us some direction last year to look at facilitated enrollment, looking at our sponsorship program to try to leverage private funding, looking at using our Cascade Care tools to try to keep people funded. So trying to do what we can at the state level to mitigate some of the impacts coming our way. I think I'll pause there. I think that's enough. Folks are working hard in Washington to sort of craft some Washington specific mitigation strategies while we're in what was going to be a time of reductions, and then obviously looking ahead, looking forward to continued dialogue on how we can keep moving the ball forward on universal coverage. That's it for me. It's enough. That's enough for me.
Yeah, thank you, Joan. That is sad news, but thank you for all the work that you guys are doing over at the exchange to try and come up with ways to help mitigate those issues. Let's see. So Jane is not here. Dr. Quanget, do you have any kind of update from DOH?
Sure, I'd be happy to share an update. Again, I'm Tao Quanget. I'm honored to serve as your state health officer. I guess one thing I'll share is Secretary Worsham in a town hall to the agency yesterday talked about how he has finished his 100-day listening tour as the new Secretary of Health, and is now going to analyze all of the comments that he's gotten both internally and from external partners and the public, to really find out what are the themes that rise to the top that will guide his actions, his priorities, and the priorities of the department. He has looked at health and approached the listening session through 4 pillars. One is health justice. How can we make sure that nobody gets left behind in the pursuit of health? Another is workforce. How can we support and strengthen the workforce of our health system? This third pillar is the public health system. How can we strengthen and support the governmental public health? And then the fourth is the healthcare system. How can we strengthen and support the healthcare system? And certainly healthcare access is a big part of that, and is one of the priorities that have been identified by the State Health Improvement Plan. And healthcare access is also an important theme in our legislative priorities. Many in Washington statute, access to preventive services right now is coupled to the recommendations from many federal bodies, such as ACIP, the Advisory Committee on Immunization Practice. But as we've seen federal changes that, including from ACIP, that move away from science-based public policy, the Department of Health is working with sister agencies and the governor's office to propose legislation that will move authority to recommend preventive services to the state. And this will ensure that people have access to preventive services such as vaccines in a way that's informed by the best available science. And as an example of some of what's at risk, we saw that the Advisory Committee on Immunization Practice last week overturned the universal birth dose of hepatitis B vaccine, which is a strategy that has helped make enormous progress in decreasing liver disease and liver cancer in our country. And so we're very concerned that the ACIP's move that is not science-based will threaten access to this very important preventive service, and want to make sure that other preventive services that we can maintain as much access to Washingtonians as possible. And that's all I have for my update. Thank you.
Thank you, Dr. Quanget. Dave is also out. So Omar, I know you're just back from leave, but do you have any updates from the Office of Equity? Is he still here?
No updates at this time. Thank you.
All right, thank you. And I would just say on the tribal side from the American Indian Health Commission, we had our Governor's Indian Health Advisory Council meeting last week, and really there were a lot of talks around Medicaid and how to work together to mitigate, any impacts and losses of coverage for our tribal members, but as well as, tribal and urban Indian health clinics also see non-tribal members. So, making those efforts to work together and look at how to mitigate. And Mohammed, do you have an update?
Thank you, Chair Vicky. No, not an update actually, but just wanted to make a small comment. I don't know if you guys have been watching the news, but my community, the Somali American community, we call them garbage because a lot of stress and depression within the people. These are low income, mostly, community. I've been struggling with that for a bit, and I'm sure a lot of people are in our boat. So, as commissioners, as we do our work, let's be mindful about our neighbors and what they're going through, the undocumented, the other minorities, and most importantly, the uninsured Washingtonians. Just be mindful. Let's do our work with that in mind. There's a lot of suffering out there, and so the stakes have never been higher. Just wanted to add that voice to you all. Thank you very much.
Thank you, Mohammed. All right. Are there other commissioners that have any updates? Any of our legislators? Nicole, Badisha, Senator Cleveland.
Thank you, Madam Chair. I'll just add to what's been shared. Last week, the Senate held their Legislative Assembly Days on December 3rd. I helped co-chair the Joint Healthcare and Behavioral Health Oversight Committee meeting, and the next day, December 4th, chaired the Senate Health and Long-Term Care Committee, and we are very much focused on the coming implementation of H.R. 1, the bill that Congress passed and President Trump signed that makes extremely deep and dire cuts to the healthcare system as we know it, including devastating cuts to our Medicaid program. Some estimates that we are looking at predict that 300,000 Washingtonians will lose their Medicaid coverage, but that's not all. The H.R. 1 includes really devastating cuts to gender-affirming care through restrictions of that type of health care, abortion-related funding limitations, and we do expect broader potential ripple effects as well, and potentially additional policy changes federally. And as Joan shared, we also still don't know what Congress will decide in terms of the federal subsidies. And so know that we are working hard and working very collaboratively from the governor's office to our agencies with all of you to attempt to do our best to mitigate these really difficult cuts and find ways to help blunt what are going to be really, really difficult and dire consequences for families. So as I think has already been shared within the Medicaid program alone, our state and every state in the country is going to need to implement work requirements. There are changes to programs that we here in our state had implemented, assist lawfully present non-citizens, adjustments to the redetermination cadence from what annually to every 6 months, changes in retroactive coverage. So this is a difficult and challenging time, and just want to acknowledge that and thank everyone on this meeting today who's engaged and helping us to move forward and find solutions to the best of our ability. Thank you.
Thank you, Senator. Anyone else? Representative Parsley?
I just want to also echo, thank you for the public commenters. I did read everything that was sent in to us. And like Senator Cleveland, the House had our updates in our healthcare committee, and it felt like one blow after another. And then our budget is another one blow after another, and HR 1 is not helping us by any means. I just would also announce that I just saw that the Senate has blocked 2 bills that would have extended the subsidies. So at this point, it does look like those will not be extended, but we can only hope that the House or a Senate bill will come forward that can be acceptable. I can tell you that there's a will that
we blunt this impact of HR1. Last year's budget cuts were bad enough, but HR1 is deadly. And I personally will be continuing to work, and I'm the sponsor, prime sponsor on 1445. And I will make sure that using that vehicle, I will keep my voice moving forward and looking for a reasonable paths forward. I will just end with this. There's always an opportunity in crisis, and maybe crisis can forward our mission here at the Universal Healthcare Commission in a way that nothing else could.
Thank you. Last call for updates from any other commissioners. All right, thank you everyone for your updates. Oh, Nicole.
Hey there, sorry about that. I was trying to find the button. There's a couple of bills that we're working on moving, I guess, with coalitions of people who are working in healthcare. One relating to the 340B drug pricing program that would help community health centers and other safety net providers. That bill will be, it's to be able to offer more affordable medications and reinvest that savings into patient care. That bill will be with Representative Tai, and when it's finally done. And then another one that we've been working on for state employees, they'd like to be able to use their, well, actually that's not healthcare related, I'm sorry. I will go ahead and stop there. But there's quite a few bills that are being talked about that is looking to reduce healthcare costs. And so we're tracking those the best that we can.
Thank you, Nicole. Anyone else? I think we almost got everybody. All right, moving on to tab 4, and Mary and Ross will walk us through the recommendations to fill the open Financial Technical Advisory or FTAC committee vacancy.
Thanks, Vicki. I can kick us off. Audrey, can go to the next slide, please. We've had a vacancy on FTAC for a number of months. I'm going to say 3 or 4 months. Pardon me. That vacancy was created when David DiGiuseppe resigned. He was not able to continue being part of FTAC. We put out the word via email and social media, and I know folks here helped spread the word, so thank you very much, that we were looking to fill the vacancy. The application period ran from October 1st to November 3rd. The entire FTAC charter is part of it's an appendix to this packet, and you'll see that there we have to have the application period be at least a month. So that was our application period. And we listed a number of desired qualifications we were looking for. One was actuarial expertise. I should pause and say that we were not requiring people to be actuaries, but rather we broadened that definition a bit to be folks who work with, interpret, act upon actuarial information. And so it's sort of a familiar part of their world, even if they are not themselves actuaries. Areas of knowledge were federal healthcare financing, unified financing, healthcare costs, an understanding of how the money goes through the system, payer-provider contracting, and then we also had a suggestion from the commission. Forgive me, I don't remember who made the suggestion, to have a current or former provider also included. So if we can go to the next slide. We received 6 applications. Thank you very much to everyone who applied. We had 6 strong applicants. This slide and the next slide gives you an idea. These folks are listed in alphabetical order. Their current work, some of them hold elected positions. We can go to the next slide as well. Their entire applications is another appendix to this. I think it's Appendix B, losing track of my appendices here. I think it's Appendix B that is all the information that people submitted, the cover letters, the resumes from all 6 applicants. And we shared those with commission members. And through internal discussions and ranking, we want to put forth 2 people to add to FTAC. If we can go to the next slide. These are the two people. This is an attempt to show how they align with the qualifications that we asked for, Sarah Hewling and Hiroshi Nakano. And again, I want to pause and just say we had very good applicants. We felt these were the people who met the qualifications and met the needs most closely to what we were asking for. Right now, the FTAC charter says 9 members. And right now, FTAC has 8 members. And we are recommending 2 more members. So if this seems like the correct path to go, our recommendation would be, and I'll pause in a moment for questions, our recommendation would be expand the number of people on FTAC. Change the charter so that instead of saying 9 members, it says up to 10, and approve both of these people to join FTAC. I think there's more detail on the next slide, Audrey. There we go. Yes. So this middle bullet illustrates what FTAC says, what the charter says right now. We added the boldface there, 9 FTAC members. So I will pause and see if folks have any questions about that before we move to suggested votes or possible votes. Oh, do you want to add something?
Just real briefly, and folks, please, if there's any questions, please feel free to raise your hand. Just one note on the recommendations. I mean, these are very soft recommendations in that we tried our best to find objective criteria as outlined in the charter to try and evaluate these candidates. And to the best of our ability, we tried to, look at the materials provided that's referenced in Appendix A to point these out, but very much want to ensure that the commission members are the ones deciding if there's any additional information or questions or follow-up that we can do. We're happy to do that. And again, all the materials are included in the packet, and happy to answer any questions on this.
Yeah, just to be clear where the information resides, Appendix A is cover letters, resumes, communication we heard from the applicants. Appendix B is the current FTAC charter. Nicole.
I would move that we amend the FTAC charter to include up to 9 or up to 10 FTAC members.
Second.
All right, we have a motion and a second to amend the charter for up to 10 FTAC members. Is there any further discussion? Any further discussion? All right. So we'll move to voting. All those in favor say aye.
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 Any opposed say nay. Okay, motion carries.
Audrey, can you jump to the next slide? There we go. Thank you. Yeah.
All right, and so the next vote would be to approve the 2 candidates. Oh, sorry, Nicole.
So moved. Vote to approve Sarah Hewling and Hiroshi Nakano as members of the FTAC committee.
Thank you.
Second.
So we have a motion and a second to approve the 2 people, Sarah Hewling and Hiroshi Nakano. Any discussion? Is there any discussion? All right. So all those in favor say aye. Aye.
Aye.
Aye.
Any opposed say nay. Motion carried. Thank you. We have 2 new FTAC members.
Thank you. And
Thank you.
if there's any feedback folks have on this process or how we showed the criteria or any additional information that would be helpful in the future for these types of additions of members, please let us know. This is a relatively new process for us, so we want to make sure we're giving you the information that you need. So please let us know if you have any suggested changes for this process. Thank you.
Representative Parsley?
I just thank you because I was reading through the resumes and cover letters and I appreciate how you lined it up. And then I also appreciated you didn't have to make us choose between those two.
Yes, thank you to staff for all their hard work behind the scenes. Okay, well, we're going to move on now to tab 5 in the packets. And we have a presentation from Vishal Chaudhry. And Vishal, I'm sorry if I said your name wrong. I think by now I should know how to say it. Who is the Chief Data Officer at the Healthcare Authority, who will talk about some of the work from the Healthcare Cost Transparency Board. Vishal will tell us about the healthcare cost growth trends in Washington State. And I believe these were mentioned in some of the public comments too. Vishal?
Thank you, Chair Lowe. Thank you to members of the Commission for having me here. Is it okay if I share my screen?
Yeah, go right ahead.
Thank you. Please let me know when you are able to see my screen.
Oh, and before you start, Vishal, I just want to reference, I know in some of your slides, it says, further detail in the appendix, and within the packet, that is Appendix C.
Thank you. Commission members, this is my first time presenting here. I appreciate the opportunity to bring this information to you. This is the same presentation that was given to the cost board in November. So we're presenting the exact same information. I appreciate any comments. I will go through this slide deck pretty quickly. I think I have 30 minutes to present, and there are 30 plus slides, not counting the appendices. So, but please feel free to pause in the middle or stop me and ask questions. A quick outline, go through what the background is, a little bit of level setting as to what we're talking about, go through the highlights, and then walk through the overall spending situation, I guess, the spending trends in the state of Washington, and go through some level of detail, statewide markets, and the service categories, and so on. This slide represents the multiple analytic work streams that support the work of the cost board. The one on the far left, the performance against the benchmark, is the particular analytic work stream that is being presented here. And again, this particular work stream focuses on the core mandate of the cost board, which is to measure the growth of healthcare spending in the state of Washington year over year. And how does that compare to the benchmark, the yearly benchmark that's been set by the board? Some context setting about the terms that we are using here. When we talk about healthcare spending, we talk about a term called the total healthcare expenditure, THCE. There are three components of total healthcare expenditure. The largest one, as you can imagine, is the actual total medical expense. That's what you and I usually talk about when we say, well, how much did we spend on healthcare? There is also an administrative overhead component, which is NCPHI, or net cost of private health insurance. People like me need to get paid when we do work, so we become the overhead. I'd like to think we provide value to the system, but we are overhead at the end of the day. So that's NCPHI. And then there are other spending categories that don't neatly fit within the claims, non-claims, or the overhead component. The total medical expense, we can further drill down, and we'll provide the detail by market, whether it's Medicare, Medicaid, or commercial market, by carrier, or by large provider organizations. The data sources are primarily the claims and information that is submitted by the carriers and the fee-for-service data from the Healthcare Authority for Medicaid and from CMS for fee-for-service Medicare.
Vishal?
Yes.
I'm not sure if you can see hands. Badisha has her hand up.
Sorry, I'm not able to see hands. I appreciate
Okay.
Hilton pointing that.
Hi, Vishal. A
Yes.
couple of questions. The first question is, could you give me an example of the other spending? Like you said, it doesn't neatly fit in the silo of NCPHI. It's just so that I understand the cost structure. Like, what's an example of other spending?
I will get there in like 10 seconds.
Oh, okay. Sorry.
This slide is so complicated. It was hard to present everything and talk about it. So it's kind of, it's animation. So my apologies for that.
Okay, I'll wait for a few more slides and then ask my questions at the end, just to make sure I understand everything. Thank you.
No worries. The green lettered call out here is attribution. And this comes up a lot around attribution of spending. We apply the attribution here at the provider organization level in this analysis. Again, NCPHI, the net cost of private health insurance. Again, the data sources are the CMS medical loss ratio data system and our Office of Insurance Commissioner filings. The other spending, Vidisha, to answer your question, that's like spending done by the VA, by our Department of Corrections in the state, and Labor and Industries, which is primarily workers' comp. And those data are provided by the agencies directly. VA, we could say that's claims spending, but the manner in which we get the data from the VA doesn't allow us to neatly package it and include it in one of the other analyses. So we call it other spending. Also, it works because from a large overall system perspective in the state of Washington, that proportion is very small. So, did that answer your question, Vidisha?
Yes, it did. I guess my confusion was that, like you said, a lot of that other spending is potentially claims and non-claims, but just because it's coming from a different source, you can't really tease out the medical expense, but just it's siloed under other spending. Is that like a correct way to interpret that it's the data source?
Those are medical expenses for the most part. However, those data sources do not follow the data submission guidelines we have. So the manner in which we receive the data, we're not able to include it in the analysis of the total medical expenditure. Like we couldn't attribute it to large organizations. They're not neatly sectioned into commercial Medicare or Medicaid, for example. So it just becomes, so it's easier to call it other spending, and then the levers associated with those would be very different. There's some things that state might have control over, others we likely won't, right?
Okay, all right, got it. Thank you.
Absolutely. This slide presents the annual cost growth benchmark that the board has set. You see that it starts from 2022. So the board set the cost growth benchmark every year, starting with measurement year 2022. We're in 2025 today. The report this year was about calendar year 2023 data. So the measurement year 2023 data is being presented this year. And that's just because of the lag of claims and processing and logistics. We look at long-term trends. So year-to-year numbers are important to look at, but we also put them in comparison and in context with the long-term trends. So that's where some of it balances out, even with the lag. The right-hand side of the slide provides the methodology, a high-level methodology on how the benchmark was calculated. I don't think we have time to get into it, but if there are any questions, I'm happy to provide more information as a follow-up. I guess I should go back and reiterate, the primary objective of calculating the benchmark is not to reflect what the healthcare industry can do. The primary objective of the benchmark is to understand and represent what the consumer can bear. So the benchmark calculation is based on affordability measures, much more so than what the industry would typically capture as, inflationary trend within the industry itself. The metrics, again, the aggregation levels for the total medical expenditure are different depending on what level of detail we're providing. So the total healthcare expenditure is only presented at the statewide level, because again, it's not feasible to break it down by market from that point on. For markets, carriers, and large organizations, it's total medical expenditure, not total healthcare expenditure. And then we do some adjustment for age and sex for adjusted medical expenditure growth rate for carriers and large provider organizations. In colloquial terms, we can call it risk adjustment, but that's really a more demographic adjustment. I'm not going to spend a lot of time on this. We made some changes. The primary care definition was updated by the advisory committee for the board, and that was implemented. So you'll see that in the slides. Also, we improved the process internally and the logistics, so the data submission process and analytics went much smoother. Some highlights: the total healthcare expenditure in the state grew at 6.2% between 2022 and 2023. The slide here just puts it in context. The benchmark is 3.2%. If you were to buy a new vehicle, you would have paid about 3.7% more over those 2 years. US inflation was 3.4%. Wages did grow at 5.9%, and that was primarily because of the 1-year bump that most sectors in the economy saw during that time frame. Also, some highlights around how the market performance. So we talked about 6.2%. That exceeds the 3.2% benchmark. And when looking at the data, that performance exceeding the benchmark was pretty broad-based. You can see, 82% of commercial carriers, 80% of Medicare Advantage carriers, 63 and 80% of the providers respectively exceeded the benchmark. On the Medicaid side, it was slightly truncated, and that actually is indicative of how the state policy managed the Medicaid expenditure growth from 22 to 23. I think I see a hand. Is there a hand?
Yes, Representative Schmidt.
Thank you. I've been thinking about the benchmark and how they set it, and you said that the benchmark was based on what the public could afford. What could you just a little bit more about the methodology, about how those benchmarks were determined by the board? I'm just curious about that.
Certainly. The methodology here, and I can provide more detailed information as well if needed, but at a high level, it's calculated based on the state median wage growth and the PGSP, state level GDP, if you will. So it's really that. Does that help? Okay, great. Other highlights, again, all the markets had substantial
Michelle,
contribution.
hey, sorry, it's Joan from Exchange. Can you back up one slide? I was just curious for your top line. Was it surprising or expected the difference between the number of or the percent of providers exceeding the benchmark between commercial and Medicare? Was that, I would have expected, is the 63 compared to 80% surprising to you, or was that expected?
It's hard to answer that question, Joan, because we've done it only for the second year.
Yeah.
And honestly, we don't have that level of insight into it. Also, the attribution methodology that I mentioned earlier is under revision right now. So, however, in general, Medicare Advantage growth rates have been higher. We've seen that, right? Okay. So, not surprised in that regard, if you will.
Thanks, appreciate it.
Yeah. I'm not going to belabor this. It's just the different categories of spending within the different markets were not the same. So for commercial, hospital outpatient spending was a main contributor. Prescription drug spending was a main contributor for Medicare. And for Medicaid, prescription drugs and professional fees were the contributors. So again, market dynamics are different, market levers are different, and that's the benefit of analyzing the data statewide, but also by market. Just on a, from a contextual perspective, looking at the long range trends, between 2017 and 2023, so over 6 years, on a per member per year basis, the healthcare expenditures have increased by almost 30%. So what I was paying in 2017, I'm paying a good 30% more than that. Well, I was in 2023. We'll see in a couple of years what 2025 has. So moving on to the actual data for total healthcare expenditure. The total expenditure in the state grew by 6.6% to almost $57 billion. We always say this is still likely an undercount. However, this is probably the closest that we have seen to a total healthcare expenditure number in the state published anywhere, just because of the way the board designs its data call. When you normalize that by per member per year, the growth is 6.2%. There are two things that at a very high level one can see from this analysis. Total spending grew by 6.6%, but the per member per year grew by 6.2%. The difference is not much. What that tells me is that utilization is not a very high contributor to that growth. It's likely remaining pretty similar. Because if the utilization were very different between the 2 years, then we would see a differential that will be larger between the normalized growth rate and the raw growth numbers. That's one. Two is when we look at the per member per year, that's $8,000 a year. Just to put it in context, the median wage of a person in the state of Washington, I want you to guess how much it was. Sorry. It's a little over 40K. That's a very big chunk of somebody's earnings that are going just towards healthcare expenditures, right? So just keeping that into context from the consumer's perspective, I think is important. This is just a comparative.
Apologies, Vishal. I think Badisha has a question and Vicky as well.
Okay, yes.
Vishal, you just spoke about utilization and actually had a question regarding that because I did go through the slides before and the tremendous increase. The first question that came to my mind was, did the utilization go up suddenly? And you said that that has not changed. So could you, repeat why you think the utilization has not changed significantly?
Vidisha, I cannot answer the why question because we haven't drilled into it. The cost driver analysis, which is a second analytic stream that's sourced from the all-payer claims database, will help us understand the actual utilization data, but we're still in the middle of conducting that analysis. This is the aggregate analysis. I'm just sharing some high-level insights from the numbers that we can see as analysts to say, not large differential, therefore this must not be a big issue. But we will learn more as we do the other analysis as to what's driving and what's not driving utilization.
Oh, okay. So yeah, I want to make sure I'm understanding it right. I see that the per person expenditure has increased a lot, but just the number of people utilizing care or one person utilizing a lot of care could be, could be underlying reasons too, not just the price increase. And as you're saying that we don't know that from this presentation.
Right, and I did not say that means that prices have gone up. All I'm saying is that utilization, there are other factors, there are other non-claims, and this is total healthcare expenses. This is not TME. So there's other expenditure included in there that could be contributing. We don't know that. We will find that out as we do other analyses.
Okay.
Yeah. Vicky?
So I have this slide we use in presentations to show like the per capita cost of healthcare for federal programs, but it's from 2018 and it's a report that the Government Accountability Office hasn't updated. And in that report, the Medicaid spending per enrollee in 2018 was just over $8,000. So I'm trying to figure out how these numbers in Washington State are so much lower than what the federal health care programs say were their costs. And I can send you this report. And I think it's probably because there are other numbers in maybe this federal report that aren't in what is you're calling the total health care expenditures.
The GAO report we're familiar with. It paints a very broad brush, and the methodology is different. Yes, I don't think we have time to go into the details of why that is different than this, but all I can tell you is you can probably find a dozen different reports that claim to report the total healthcare expenditure in the state of Washington, and the staff have looked at all of them in designing the data call, but also then comparing and contrasting as we collect the data and publish it. Yes.
Okay. I didn't.
Sorry, Vicky, it's not
I'm new to data like this, and I'm used to like how the federal data works. So and I've been watching the Healthcare Cost Transparency Board videos after the meetings and stuff, and trying to keep up. But I feel like you could parse it out any different way to get the results you want, and I worry about that.
Thank you. Mohammed, did you have a question?
I do. Thank you very much, Vishal, for the presentation. My question you might answer it down the road, but do we as commissioners have the ability to give, for example, it's outlined in our charter and in the bill that established the commission. Can we give you parameters that you could actually use when you're analyzing this data? For example, accessibility, how accessible is it for people? How much does it cost for an individual Washingtonian? How much of that, like basically, can we give you guidelines on what criteria or parameters to focus? Because I know from the analysis, there might be other factors that are not focused on that might be influencing the numbers themselves, and then So is there a way that we could send you a list of things that we're interested as commission, and then you narrow down your analysis just specifically for that, because that's what's important for us to figure out what how expensive this thing would be for the state.
Yes, analytically, anything is possible in terms of the process. I will defer to Ross as to how that kind of, I guess, ask or those ideas could be relayed from the commission to the cost board. And then we could take that into account.
Yeah, thank you, Vishal. And we can follow up more on this, Mohammed. But kind of as we had stated, this data call is run through our Healthcare Cost Transparency Board, and we have some statutory guidance that states how we do some of this work, defining total healthcare expenditures and some of the additional analysis. But as Vishal noted, kind of the supplementary analysis is a cost driver analysis where we dig a little bit deeper based upon the information we see from the data call. And perhaps we could work with some commission members to see what detail you're interested in that we could potentially incorporate into that type of analysis. But I just want to reiterate, this is kind of the cost board's product, not to say we can't incorporate some of that information, but we will have to work collaboratively with the Healthcare Cost Transparency Board and directing what analysis we need to do. So happy to follow up on that. And that would probably be a good conversation about how we can work together to, get the best results out of this analysis. So I hope that responds to your question, Mohammed.
It does. Thank you very much.
Okay.
I see, Sandra, then your hands up. I cheated. I asked my team about Vicky, your question. There is a simpler explanation than what I was trying to conjure up. The per enrollee expenditure numbers will always be higher. The per capita numbers will always be lower because the denominator in this slide is the entire population of the state. So that hopefully that helps.
Thank you.
Sorry, Senator Cleveland.
Thank you, Vijal, and I know Representative Schmick's been patiently waiting as well. I am just curious. I'd like to ask for a little clarification. Does the total healthcare expenditure figure reflect the total actual cost to providers, clinics, hospitals of providing that care?
Let me parse that answer a little bit. We often use the terms cost and spending interchangeably. The word cost is in the Healthcare Cost Board's title, so we present it as cost. What the data that we're presenting actually is expenditure. So these figures, so the $56.9 billion that you see here, that is pretty close to the total amount of healthcare, total amount of money that was spent on healthcare for Washingtonians in calendar year 2023. It went to providers, it went to middlemen, it went to actuaries, it went to, all sorts of different entities that are in the mix. But that is a total spending. Now, what it cost the providers to provide that care, that is not reflected in this analysis.
Thank you for that. I appreciate that because I do try to keep in mind always Medicare reimbursement rates don't cover the full cost of care, and Medicaid, most certainly, those reimbursement rates do not even come close to covering the cost of care. So thank you.
Representative Schmick.
Thank you. Of the differences of the 2 years you're showing, like the 6.6%, how much of that was drug spend? And the increase in just drug spend alone for that component of that 6.6%?
We will get to that in a few slides. I don't remember the numbers off the top of my head, but I know we have it. Okay. So again, this is the year-over-year trend of the per member per year growth. And as you can see, 21 to 22, which was the first year that we presented this information, calculated and presented against the benchmark, was 3.6%. The performance for 22 to 23, it's 6.2%. And of course, you see 19 to 20, that's during COVID when healthcare activity pretty much went down to pretty close to nil for part of the year. And so we see the expenditures follow that. This is an interesting way also to look at, we say, total $6 billion was spent, $56.9 billion was spent. Well, where did they go? So total medical expenditure is about 90%. So that first part of that one slide, the contextual slide, the TME, the claims, non-claims based information, that's 90% of the total expenditure. Out of that TME, you can see out of the 90 cents, about 18 cents is Medicaid, 34 is Medicare, 37 is commercial, right? So from we can talk about percentage rates, the growth rates, but it's also useful to look at the absolute total because that helps us understand how much impact it's having on the overall total expenditure increase. This slide presents at a glance the different components that we saw on that first contextual slide, the commercial Medicare, Medicaid, but also the net cost of private health insurance and those other spending categories. And you can see the difference in the growth rates in the right-hand side of the chart, but also the proportion of the total spending, right? So even though the net cost of private health insurance actually went down year over year, it is such a small component that it didn't have a meaningful impact in lowering the overall spending, right? So that's the relationship between the purely normalized percentage calculations and the absolute spending figures. And there are 9 states that have a cost growth board or something like it. And compared to other states, Washington, as you will see, is we're smack in the middle. We're the green line in the middle, and we have been. For our baseline comparison, we did this, and then last year and this year, we've been pretty consistently in the middle of the pack in terms of performance, both for the total expenditure, but also by market. Now I'm going to switch to total medical expenditure. Again, reminding this does not include the total, the net cost of private insurance or the other spending categories. This is just claims and non-claims data that we received from carriers, from HCA, and from CMS. As you can see, the per person spending growth by market here, the top chart is just the raw spending, the total numbers. The bottom chart is normalized per person, right? And when you see the total spend, you'll see that, oh, commercial is much higher, and then Medicare, and then, Medicaid, with the average coming to about 7.9% for total, the TME, not THCE, TME, it's 7.9% growth. But when you normalize it by person, per person, it kind of comes to like 7.2% for both commercial and Medicare, and then 5.2% for Medicaid. Again, the benchmark is 3.2%. So that's where it's, it juxtaposes to where we're performing to where we are expecting ourselves to perform. And as we get into the detail, professional services, it's interesting. It includes primary care, professional specialty, and other claims. However, we're not able to parse it out for Medicare fee-for-service, just because of the way CMS provides us the data. And we have asked, and they have chosen not to follow our decisions, our data submission guideline, and provide us the data the way we would love to have it. That's just the reality. So when we look at the total medical expense in terms of which category of spending it is, not just by market, but category of spending, you will see that the hospital and professional services, they constitute about 2/3 of the total medical expenditure, which you would, expect. I mean, it's intuitive. Prescription drugs is about, 1 out of every $6 goes to prescription drugs. So about 16% of the expenditure. The reason this becomes important is when we look at the growth rates. Some of the growth rates, you will see that, oh, non-claims expenditure grew by, X%. Yeah, but it's a very small part of the total pie, right? So the overall impact of that might be smaller than what that percentage growth number itself indicates. To look at a slightly different way, the same thing, we looked at the Medicare, commercial, and Medicaid, where 37%, 34%, and 18% of the total expenditure. If we break it down by, kind of insert those spending categories within each of those markets, you will see that there are slight differences between the markets in terms of how that is split. Hospital inpatient and outpatient, for example, in commercial has a different proportion, a larger proportion of spending than in Medicaid. Right? That's just the nature of how the market works. It's important for us to understand this from an analytic perspective, but also from a policy perspective, because that means that the levers that we have at play to affect, or to impact the growth trajectory in those markets will likely be different. A lever that would work well in Medicaid may not work the same way on commercial side, right? And vice versa. So we need to be cognizant of that. Same kind of chart that we had earlier by spending market type, by spending category. And you can see here, again, the growth rates, on the right, but also the total expenditure, if you will, per member per year. That gives you the amount of spending. And Representative Schmick, you were asking about the growth rate for prescription drugs. So from 22 to 23, that was about 10%. That's a statewide. It's different by market, but statewide was 10%. Again, lots of charts. I'm going to blow through some of them because they present information in a slightly different take that's useful for different discussions. But this shows us the contribution to growth. Like if the total growth in statewide was 7.3% for the total medical expenditure, how much of that was professional fees? It was 1.8%. How much of that was prescription drugs? The green box, that's 1.5%. So on and so forth. So it helps us understand in the different markets, you will see that, for example, hospital outpatient growth rate was larger in the commercial market, comparatively speaking, than, let's say, in Medicaid. Curiously, in Medicaid, hospital inpatient was actually a decrease, a slight, even just a minuscule, but a decrease as compared to commercial, which was a 1.4% increase, right? So again, different markets have different characteristics and how they perform. It's good to understand that as we look at potential policy levers. Comparing the growth by service category across the different service categories, again, between the other states and Washington, you'll see Washington, again, we're in the middle, we're in the median, middle of the pack. Claims other is an odd category because it's a catch-all for everything. So you'll see, Massachusetts is way high there because their categorization of other things, the catch-all category is much higher than maybe other states, and Washington's slightly higher than the other states in that space. But that number, in totality, that number is so small that it doesn't make a huge impact on the overall market performance. I personally really like this bubble chart because it gives me at a glance a ton of information. I can look at that chart where we saw the service categories where, I pointed out that prescription drugs grew at 10% year over year. This gives me the statewide performance by the different service categories, but also the contribution of those categories. Like how big was that expense to begin with? That's the size of the bubble, but it allows me to compare the statewide performance against the three large markets, Medicare, commercial, and Medicaid. So if you look at the statewide one on the top left, you'll see the gray, peach, and green circles are large and they're big. That's the professional outpatient, hospital outpatient, and prescription drugs from a statewide perspective. But as you get into the market by market charts, you'll see that the hospital outpatient is primarily driven by the commercial market. The professional services is primarily driven by the Medicaid market, and prescription drugs is driven by Medicare, but also Medicaid is right there in terms of the growth trajectory for those, right? So again, the same data just presented a different way to help us understand what do we make of it and what can we do with it. I've been going really fast. I'm going to pause for 1 second and see if there are any questions. Again, I apologize. A ton of information, ton of data, but happy to pause and take questions if there's.
I think you're good to keep going.
Michelle, I really like this view. I really like the comparison across the three markets. So appreciate you and your team giving us so many slices of it.
You're welcome. So the next few slides go into the detail of this summary chart, market by market. I know we are at 3:50, so I'm not gonna linger on any of these slides. If you would like me to explain something on a slide, please raise your hand and call it out. Again, statewide, commercial, the differences I've already pointed it out with Medicare as well. You'll see the non-claims and claims other bubbles way up there on the left side. Their contribution is high from a percent perspective, but their overall impact on the market is not that high because they don't constitute that much of the market spend. This is Medicaid. Something I want to point out is between Medicare, commercial, and Medicaid, you'll see the bubbles are really towards the left of the chart, which is the amount of spending, which we saw. 37%, 34% between commercial and Medicare, and Medicaid was 18% of the market. So that it shows in the data, whichever way we look at it. I want to take a couple of minutes to go over the primary care expenditure. This year, we're using a definition that includes not just the services delivered and by whom, but also the place of service. The advisory committee to the board, the primary care advisory committee to the cost board refined their methodology to calculate and identify what is primary care so that we can then be better informed and are able to better inform the legislature against the 12% target that the legislature set for primary care spending in the state of Washington. So with the new definition, which is the dotted line, you'll see that the performance is slightly lower, which we expected. We expected because it is more refined than the earlier definition, which was somewhat vague and somewhat more inclusive, if you will. The trajectory between 22 and 23 is positive. The percentage spend is still about a third of what is expected by the legislature. The target is 12%. We're spending at about a little over 4% across markets. Medicare Advantage is really low, which from on the one hand, we don't have this level of data from CMS for Medicare fee-for-service, so it doesn't present the whole Medicare market. It's just Medicare Advantage. But for seniors, their utilization of primary care, at least the spending on primary care for seniors, seems to be really low. I'm sure there are reasonable factors and plenty of reasons why that is, but that's something that can be a follow-up analysis from this.
And apologies, Vishal, we have a question here in the room from Representative Parsley. Please go ahead.
Thank you. This is great data. Lots of questions. I'm not going to take up time, except for this one. When I was reading through the slide deck, isn't this impacted by the amount of ability for a primary care to actually get payment from Medicaid, Medicare compared to commercial? So the reimbursement for care is going to be lower with those two than commercial. Is that correct? Or am I misinterpreting?
I think the short answer is yes. The long answer is yes. The total spending depends on the actual reimbursement rate or the pricing, but also the utilization and the volume of services. What we're seeing here is because we've done the analysis in the all-payer claims database around primary care spending as well, we know that the utilization really hasn't gone up much either. So it's the actual utilization of services and the reimbursement levels of the services are probably contributing just as much to that. Does that answer your question?
Yes, thank you.
A real quick slide around performance against the benchmark for large provider entities and carriers. I mentioned in the summary slides that it was pretty broad-based, the performance above the benchmark, and you can see that. In the presentation to the cost board, one of the board members pointed out that, hey, there are a couple of dots below the line, and so some carriers did perform better than that? And the answer is yes. I mean, that's why it's not 100% above the benchmark, but very few that were able to meet the benchmark. For the most part, it's a pretty broad-based performance of the market that did not meet the benchmark set. In other words, we can't point and say, these are the entities that should be doing better. The whole market was performing at a certain level. Key takeaways essentially states the highlights from the first two slides. So I'm not going to belabor that. If there are any questions, please feel free to send questions directly to the email address on the slide or route it through Ross, and we'll be happy to do that, to answer those. And with this, I will stop sharing. I'm happy to take any additional questions.
Thank you so much, Vishal. You did such a fantastic job talking us through that and responding to questions. Wanting to see if any commission members have any additional questions at this time.
Vishal, can you just give us the 30 seconds on what comes next with this data and your analysis? Sort of where you all are, where you're headed with the next level of analysis with this data?
Sure. So this analysis is one of the analytic work streams that supports the board. This provides the aggregate picture for the state. The drill down from this will come from the APCD. So we're working on what we call a cost driver analysis right now. Our target is to have that available to the board and presented to the board in the spring timeframe. That will help us understand, within each market, well, what are the levers? Are there clearer indicators in the data between, price and utilization, for example? What does that look like? So we'll start drilling into that a little bit more.
Awesome. Thanks.
Of course.
Do any other commission members have any questions for Vishal? All right. Well, thank you again, Vishal, so much for that presentation. That was excellent. And I believe we are transitioning into a break here, scheduled to return at 4:10. So again, we'll take a 10-minute break here and return at 4:10. Vishal, again, thank you. Thank you, commission members, for your excellent questions and thoughts on this. And again, welcome and encourage folks to submit any questions, critiques related to the data call, and we'll be happy to funnel that back to Vishal and his team. So thank you all. See you at 4:10.
There we go.
Are we ready? All right. I hope you're all coming back to the meeting. If you can turn to tab 6 in your packet, Mary will give us an update about the Commission's 2026 work plan.
Hey, good afternoon, everybody. If you recall, in our last meeting, we had an update on a proposed work plan. We've changed it slightly. I'm presenting something slightly different today. So Audrey, if you could go to the next slide. This is the overview. I'm going to give a quick staff update, the work plan status, the revised proposal for 2026, just a real quick overview of what happens to the straw proposals and how we envision using them, and talk about our next steps. So the staff update, we're going to stay on this slide for this one. This is not my favorite thing to announce in this meeting. Our wonderful policy analyst, Allie Power, has moved to a job at another agency. So she has done, she did tremendous work. A lot of her work, I think, was invisible to the outside world. She built a lot of amazing systems that we use internally to keep us on track. The good news is she's still working in policy. So there's a good policy mind still working for the state of Washington. And that leaves us with reduced staff. We work, the commission team and the cost board team work very closely together, and we are in the process of reassigning and refiguring out who is doing what. But amazing staff, but no matter how you slice it, we're down a person. So that's where we stand right now with the staffing. So the next slide, please. This is the familiar work plan update that we try to keep us on track with the various design elements. The last time we looked at this in October, it had less green on it. So that's happy news today. At the October meeting, we approved the eligibility straw proposal that turned green. And since we last were together, we submitted the 2025 annual report. We submitted that. I forget the exact date. It was due on November 1, and we submitted it one of the last days of October. So that has been submitted to the legislature. The provider participation and reimbursement on the far left is still that light orange shade. That's in FTAC's hands, and there'll be more detail on that in the FTAC update, which is the next item on this agenda. So the next slide. This has been our workflow to date. We shared this last time around when we were talking about workflow, excuse me. One topic kind of meandered its way through from FTAC, then to the commission, then feedback back to FTAC, back to the commission. This year, in the coming year rather, we're proposing some parallel work streams. So not so much work going back and forth, but some work living with FTAC, and FTAC reporting up to the commission and getting the commission's guidance, and some work living more with the commission. So the next slide, Audrey. This is slightly different from what we proposed last time. The top part is the same, that provider participation and reimbursement continues to live with FTAC. The recommendation goes to the commission, including the guiding principles on that in early 2026. Financing also goes to FTAC, lead role in financing. What we are proposing differently today is, if you look at the last three elements on the list, enrollment, infrastructure, and governance, we had initially thought that we would, over time, stand up an operations committee to take on that work. But with staffing levels and capacity to support the committees, that doesn't really seem feasible. So what we are thinking is that enrollment, infrastructure, and governance become the purview of the commission. Those are the elements that the commission takes on in the coming year. So the lead role in designing those elements. We have an established workflow. We have some templates for straw proposals. We can adapt that to fit more the commission work stream and the commission's work. It does eliminate the need for an operations committee in the future, and it gets us to the completed set of core elements sooner, because that operations committee probably would have been late 2026, but instead these three pieces would come to the commission sooner. So it gets us to the end of the list earlier. The next slide. Part of this revised proposal, still the commission will be looking at interim solutions. That is still part of the charge of the commission. Look for things that could serve as pilots for an eventual universal design. when the funding and the staffing are available for that, and integrate with other boards and programs. I think it's pretty clear after Vishal's great presentation that there's Healthcare Cost Transparency Board, Universal Healthcare Commission overlap, so we would integrate with the other boards, look at their work. Washington has a pending application for the Rural Health Transformation Program. Washington and I think every other state. CMS has said they will have an answer on that about funding levels and what they're funding on December 31st. So we don't know what that looks like yet, but we do foresee interplay between the commission and RHTP. There's also the Prescription Drug Affordability Board. I know we had questions earlier today about drug prices as well. So the commission will continue to develop recommendations for the legislature, focusing on the access to care and affordability, and adapt the work of other entities. And the bottom bullet there, potential considerations of bills in the next session. Some bills have been pre-filed, not all bills. So certainly that is something the commission will be keeping an eye on, looking to our legislator members to let us know what's going on. And in the past, this commission has weighed in on various pieces of legislation. And if the legislation pertains to the work, they will imagine the commission will consider it again. And then our next slide. Oh, this was Ross's, who just stepped out of the room, which was to just give a preview of what the cost board is likely to be taking up in the coming year. And we have this slide in here just to give people a sneak peek and to think about where it might overlap with commission work, looking at market oversight, looking at spending growth, and also looking at primary care utilization. And again, I think if we think about Vishal's presentation today, we can certainly see where that plays into commission work. And the last slide, unless you have more to say about the cost board. Okay. We get questions now and then about the straw proposals that we put together as we complete each design element. And internally, we're wondering if maybe straw proposal is not the right thing to be calling it. We can change the name of it if that makes more sense. And I can tell you how we see them and how we use them, and then see if this resonates or if you have a better name for what they are. As the commission comes to a conclusion of each of the design elements, and this has happened with eligibility, benefits and services. Right now, provider reimbursement is in play. We come up with a proposal that we call the straw proposal, and we call it that because it's not set in stone, and we expect it to perhaps change down the road as we know more, but it is what we can do now for this piece. We incorporate them into the annual report so the legislators can read them. And what we envision eventually is that all of these things will need to be coordinated and integrated and reconciled. You know, we may come up with something in enrollment that, you know, has to be reconciled with something we did back when we did eligibility. So that's part of the reason we say they're not set in stone, because at some point they all have to be put together into a cohesive package that hangs well together. And that also forms the recommendation to the legislature when we get to the end of all of these elements. So I think I only have one more slide, which is next steps. Oh, but I'm going to pause to see if anyone has questions about what I've gone through. Vidisha.
Yeah, so on page 83, where you have the HCCTB preview, and you have market oversight, spending growth, and primary care utilization, is it also possible to track other type of utilization? Because I guess I'm thinking that we want to encourage more primary care use, hoping that it would reduce other types of utilization that's more expensive. And is it possible to track that to see whether that is indeed happening or not?
Okay, you're back in the room. Good.
Thank you for that, Vidisha, and apologies. So these are the primary topics that we'll be discussing at the cost board over the next year. And that's a really good question related to primary care utilization that I can bring back to the cost board. As we were visualizing it, this was in response to seeing that with our 12% primary care expenditure, and we came in at about approximately 3.7% for 2022, as Vishal showed us, that we need to spend some time and consider some recommendations to be able to increase the proportion of primary care spending. But I do think that you ask a really valuable question about tracking other forms of utilization to better understand that. So I can certainly bring that back to our cost board team and specifically the data team to see if that's something we're able to incorporate.
Okay, thank you.
Thank you, Vidisha.
And Representative Parsley, I think you have a question, and
Thank
Harry,
you.
oh, go on.
No, it's sort of I'm thinking with my legislative hat, and I know there's two other legislators in the room, but even with the cost board, it would be interesting or important for us to hear about potential policies that will help with the cost drivers. And, I'm thinking of even things such as litigation caps, which is a scary word to say in a room because lawyers will go unglued. But, things that reduce the overhead there. And then I would also be curious because we know we have a link to some restrictions federally. Are we going to be reaching out to our federal delegation at what points will we trigger that to say, hey, let's reach out to our senators or our, the key Congress people, because there's multiple, that to get their help in this process.
Thank you, Rep. Parsley. That's incredibly helpful. And I believe Mary went over this. So the two-prong call of the Universal Commission is establishing the unified financing system as well as the transitional solutions. And so we're hoping to do what you had just mentioned of really trying to bring those, what we call policy levers or policy strategies, to try and address cost growth to the Commission for just this exact type of feedback and input, which then we can bring back to the cost board and kind of build into our recommendations and considerations. So that integration is something that we're really hoping for this year. And for better or worse, our staffing restrictions, our staffing, decreased staffing makes it more incumbent that we are sharing information back and forth as we have less internal capacity. So that is certainly our plan. Regarding outreach to the federal delegation, I think that would be something the cost board or the commission would need to decide probably on a case-by-case basis for an individual recommendation. But so I'll defer to the boards themselves, but that seems aligned with something they could do. Thank you.
Okay.
And Harrison, please.
Did you want to add something?
Yeah, just to follow up on Vidisha's question about utilization. So for context, I'm staff to the board, and so we are tracking primary care utilization, but also utilization within different spending categories as well, different service categories, things like hospital outpatient, hospital inpatient, pharmacy spend, and I can follow up with some slides to that effect. Like Vishal said, there will be an update next March, but there is data from last year that actually goes through 2023 that should.
That'll be great. I'm actually really looking forward to that March presentation of price and utilization, because I think that will be the whole picture. We just saw one side of the coin, and so yeah, that extra information will be really helpful. Thank you.
Thanks, Harrison. And Nicole, looks like you have a question.
Yeah, just real quick, under the market oversight, would it be possible to include information about the difference between the nonprofit healthcare providers and the for-profit? Like seeing the kind of that broken out a little bit cost-wise?
Yes. Well,
Okay.
Thank you for that question, Nicole. I just want to make sure I'm not over promising. So I think that in the context of our review of these topics, we typically invite experts, and we'll also be able to draw on some of our data. But so I guess I don't want to promise that we would be able to have that data, because I'd have to check with our data team. But at the very least, we could certainly look for experts or existing literature that kind of discuss that point, and see if there's anything that we can do to extrapolate to the Washington market. But these are fantastic questions, unless Harrison has an answer off the top of his head, that we could discuss with the data team and see what we can and can't do kind of with the data we have access to. And just to give a little bit more insight, just briefly on the market oversight, we were really thinking about trying to analyze some of the impacts of consolidation on what, if any, impacts there are of consolidation on costs in the Washington market, and trying to analyze that as a specific sort of discrete analysis. Also looking at impacts of private equity and anti-competitive contracting, kind of in that bundle of market oversight. And we're anticipating each of those three topics that you saw: market oversight, spending growth, primary care utilization, to roughly make up 3 meeting blocks over the 2026 year for the Healthcare Cost Transparency Board, subject to obviously any breaking news or changes, and really encourage folks, if you're able to attend those meetings, we can circulate the upcoming calendar, but your insights and guidance would be invaluable as we kind of go through that process. So welcome any additional comments you have.
Representative Schmeck.
Thank you. Any idea about how you would go about in measuring consolidation and the effects that has had on pricing?
Thank you, Rep. Schmick. I am going to recognize my lane, which is not in that detailed data. We have had discussions internally with our data team of some proxies that we could potentially use, whether it's purchasing power or some other proxies, to get an idea. And there would have to be, to just state what we can and can't say based upon what that analysis is. But happy to follow up with you on kind of what we're thinking, but just want to make sure I'm consulting the right folks before I give you incorrect information. So please let us know if you'd like kind of what we're thinking currently, and we can provide that to you.
Vicki.
And would that include like loss of services too? Because I think that's a big issue that people are concerned about with these consolidations. I know you can't answer that, but just putting that as
Absolutely
an item
Thank
to think
you,
about.
Vicki. And yeah, we've been thinking about taking a look inside that market oversight meeting topic about what notices facilities are required to provide, both with full facility closure as well as service line closures, as part of that market transparency and insight. And so trying to take a look at our system and seeing that, as we've heard instances, where OB department might close, and obviously that's a crucial service for anyone in the region. And so wanting to make sure we're understanding and have adequate protections for patients related to that. So we're hoping to also do some analysis of our current laws and make some recommendations if appropriate on that topic.
Any more questions? And thank you, everyone. Did you have something else? Excuse me. Here's my last slide of the work plan update. I'm bringing us back to the work of the commission in the February meeting, talking about the 3 design elements that were on the slide a few slides ago, which is enrollment, infrastructure, governance. The plan is to get to work on these in February. These are among the things we need to do. I welcome additional input, but first of all, clarify the definitions of what each of those elements means, and also begin work on enrollment, because that's the first one on the list. So we're just going to get started with that one. And if anyone wants to put up their hand or work with us between meetings or send us suggestions about how to get started or any of that, we welcome it. We still have the commission mailbox in the chat, so happy to have the input. And that wraps up my part for the work plan.
And I just want to offer help I'm excited we're getting to this part because I feel like we've got a lot of foundational work and enrollment. I worked, and Joan's here too, but when they were standing
Yep.
up the health plan finder, that was some interesting work, huh, Joan?
Yeah, I was just gonna say, Vicky, if you're in, I'm in, I think we've done a lot of thinking about how to try to leverage various data sources and leverage existing tools to try to get us to a place where we can more seamlessly do this. So, yeah.
Thank you.
I will help after session.
Fair enough.
I see
Mohammed's
Mohammed's
handed
hand,
up.
so I'm hoping he's volunteering too. Mohammed.
At your own risk, Mohammed.
Thank you, Chair Vic. Yes, I am willing to help. Please include me.
Thank you so much.
Same here.
Very much appreciated, everyone. Thank you.
All right. Thank you, Mary and Ross and everybody. Our final agenda item today, Ross and Mary are going to give us an update from the Financial Technical Advisory Committee, or FTAC. Just a reminder that I made a New Year's resolution not to use acronyms, and it is just about killing me. Thank you.
Thank you all. Thank you, Vicky. So this will just be a quick update on the Finance Technical Advisory Committee meeting last month. First, briefly reviewing public comment. We got a good question about how we're documenting completed work. And Mary spoke to this in the last presentation regarding our straw proposals and, of course, seeking any feedback on some name changes to clarify that purpose. But those are currently our ways of documenting work. As Mary noted, they are iterative. We do expect them to be updated as we go through other topics, but we wanted to get words on paper that is kind of documenting where we are to be transparent to legislators and the public, so that they can provide us feedback and input, but also viewing those as iterative documents that will be updated as we go through other topics. So just wanted to provide that response. We also heard about an event that included Universal Healthcare Advocates and Senator Hasegawa. Vicky, I believe you attended that event. Would you like to share any impressions?
Sure. And there were two events, and I was only able to attend one, but it was like a very robust group of people who we regularly see in our public comments. And it was a really good conversation. And I think I heard a lot about concerns, but really trying to think about finance and where the funds could come from, and really kind of focusing on that this year. And so this is not me, but I might agree with it, a lot of conversation about taxing the rich, and that, there's pushback from the administration on that, but really people who really support the move to universal healthcare. And as we've heard in our public comments too, that the sooner rather than later.
Thank you for that update, Vicky. And also wanted to provide just a quick update. During the FTAC meeting, we heard a presentation from thank you, Audrey, from our legislative lead regarding SB 5083, which was passed last legislative session. That is implementing reference-based pricing for our PEB and SEB, or public employee and school employee benefit plans. This has a very cool innovation of incorporating value-based purchasing into our market, and there's some strong expected savings from this. And we encourage folks to click on that link if you would like to view that presentation. The update we received is that the reference-based pricing implementation is in the rulemaking stage currently. I believe they recently filed a CR 102. If folks have any comments they'd like to make on that. The rules are primarily focused around a lot of the administrative and operational aspects of this. So would encourage folks to check that out if they're interested. And just wanting to note again, full implementation of reference-based pricing related to PEBSTEB begins in January of 2027. So still very much in the working and rulemaking phase of this. And so very much looking forward to any comments or feedback folks have, and wanted to direct you to that presentation by Evan Klein, which was excellent. And I see a hand up
It's
from
Rep. Schmick.
Representative Schmick. Please go ahead.
Thank you. When you're doing this and you're looking at the utilization of policy for reference pricing, does the financial viability of the hospitals play into that, or is that just not even considered?
In terms of the rulemaking aspect, Representative Schmick?
I just think that in order for a full decision and disclosure, I think it's something that needs to be looked at along with that.
Okay, so that you're referring to impacts to hospitals, particularly related to finances regarding the implementation of 5083.
That would be correct.
Okay.
I think that's part of the conversation that needs to be considered.
Okay. And all right, just to clarify, is the suggestion for perhaps like the cost board or another body to do some actuarial work to see those impacts? Is just wanting to make sure I'm understanding the comment, Representative Schmick.
I just think that whoever does it really doesn't, not that important to me. I just think it needs to be part of the overall conversation about financial viability.
Okay, thank you. That is a great point, and that's something I'll elevate to that team and see what information we currently have. Thank you.
And we also can provide that as feedback to FTAC, because reference-based pricing is one of the reimbursement mechanisms they are considering. So we will make sure that they consider that as well.
And to the point Mary just made, this topic has come up frequently at FTAC because this is consideration for one of the building blocks of creating a universal or unified financing system of reference-based pricing and hospital global budgets would kind of be an incremental approach to that system. So they've been very interested in that, and that's another great forum to bring those comments. FTAC is also continuing its work to make recommendations for provider reimbursement in a universal system. We formed a work group to help us with creating those recommendations, working on guiding principles, which will then come to FTAC for review and then ultimately come back to the commission, I believe in the form of a straw proposal when it's been all shaped, and we'll come back for the commission's review and comment.
Yeah, actually, we anticipate two different things coming to the commission. Right now, FTAC is working, Ross mentioned a moment ago, on a set of guiding principles for provider reimbursement. So if the schedule goes as we envision it, at the February meeting, draft guiding principles will come to the commission for consideration. And at the April meeting, the first look at the draft straw proposal for provider reimbursement will come to the commission. We don't anticipate it being in April. We don't anticipate it being far enough along to be approved, but we like to bring the straw proposal to the commission at least once, get feedback, additional questions, and then we take that back to FTAC, they revise it, and then it comes back up to the commission, which is what we did in 2025, and that system worked.
And just to be clear, remember that we made the decision to be working on two things at one time. So we'll also be working on provider enrollment while they're working on the provider reimbursement. We're going to be kind of doing two parallel paths.
Yes, we are trying to harness all of our resources to move forward as quickly as possible. So yes, thank you for.
So be prepared. These will be 3-hour meetings, really stuffful.
Yeah, and they are complicated topics. And kind of speaking of a complicated question, we did receive a really good question from our FTAC members that we wanted to bring back to the commission for some feedback. I'm sorry, Audrey, I'm not giving good direction on slide changes here. We previously talked about FTAC sunsetting after the completion of the two topics that Vicki had just mentioned, provider reimbursement and financing, which you can see on the work plan. And just to clarify, sunsetting or ending the FTAC work group after the completion of that work. And FTAC asked a really good question of, well, if we wrap up, what is our final product, if any? And thought that was a really good question, and wanted to bring that back to the commission to see if if there's any feedback related to what a final work product might look like for a finance technical advisory group. Well, I guess we have another question, but I think that's a big enough question to present it first. So if anyone has any feedback in terms of what a final work product might look like from our Finance Technical Advisory Committee, we'd welcome that. And also acknowledging that we will be having straw proposals related to the individual topics that they're working on, like provider reimbursement and financing. So those already will be produced. But if there's anything additional or some type of more comprehensive roll up that might be useful, would love that feedback. And not seeing any hands jumping, I guess I'll kind of incorporate the second question into this, which is another alternative. Rather than fully sunsetting FTAC, would it make more sense for us to maintain FTAC and not necessarily have regular meetings of the group, but maintaining that membership, which are incredibly valuable and knowledgeable folks related to healthcare financing, to remain as kind of a resource and advisory body to the commission? So alternatively, rather than sunsetting it, we would keep them together and not meeting on a routine basis, but available for any technical financial questions that may arise as we continue with our modeling and work plan.
Yeah, in the spirit of volunteering others for work, I would love and appreciate the FTAC being maintained as a resource and advisory body. Just particularly given like capacity and resource considerations for the commission itself. So
thank you, Joe.
Question.
I would second that.
Okay, thank you. Okay.
And I agree too.
Thank you so much. And Senator Cleveland, please go ahead.
Oh, I'm just going to third that.
Okay. Okay. Yes, please go ahead, Rep. Parsons.
And forgive me if this is because I joined this commission late. I'm wondering, I agree with everyone. We should keep them as part of this. But I'm also thinking with the fiducial hat on, the budgeting process, which is not just revenue, but expenditures. And how does that fit into the governance model?
That is a fantastic question. I feel bad. I don't want to sidestep the question, but I think part of that relates to what Mary was talking about defining those terms, because we have infrastructure. Speaking personally, I've struggled a little bit. We have infrastructure and governance in understanding exactly what we mean in those two categories. My short answer would be, I think we need to define governance to figure out the answer to that question. But to be fair, I am sort of sidestepping, not intentionally. So I apologize.
But we will be working on those definitions.
We will
at the next meeting.
Yes.
Yes.
So apologies. I hope we can answer that question at our next meeting.
I think the second question was obviously easier to answer than the first question, right? I mean, do we like some kind of report, a table, something we can like keep on the website to help people know what we've already worked on and where we're and again, reminding people that none of that is written in stone. If things change, we might have to change some of the things we've put forward, but it'd be nice to have it somewhere where people could like see it and say, oh, look, they've figured these things out already.
That's a
I would love
fantastic.
that.
So maybe a dedicated portion of the commission website that specifically and clearly outlines that these are the straw proposals that are speaking to the different design elements. That's a great call out. And
Yeah,
that is,
maybe a different word than straw proposals.
yeah.
Nobody likes that phrase.
Yes.
I mean, because they are like, it's like the bones for, what we're building, or it's some foundation. I can't think of maybe tomorrow morning I can come up with some words. If anybody has any ideas, Mohammed.
Yeah, I 100% I agree on that. Maybe a phrase or name we could use is, because we know the public Washingtonians through the public comment in the past have requested some sort of like progress bar, like something that shows how far we've come and how far we have to. Maybe progress update or something around to get people engaged and anticipating their contribution and involvement in this process. I don't know, but I was just thinking about that one.
No, that's a great suggestion, Mohammed. I guess the first thing that comes to mind is that would probably be based on our work plan, which we could show progress in. We're quickly approaching the final elements. And just wanting to be clear that that's not once we finish our work plan, that doesn't necessarily mean universal healthcare will come at the end of that. So just wanting to be clear and not give any false impressions. But I do love that idea of showing our progress and being transparent and accountable to the public and community about the progress that we're making. So thank you for that recommendation.
Anybody else have any thoughts on the final, what should come out of the Financial Technical Advisory Committee?
Vicky, I also have thoughts, but I also feel like I need to
think of it.
I am not all the way there, but I was sort of somewhere in between you and Mohammed and thinking about, it's separate from a work plan perspective where it's like, here's what we've done and where we're going, and that's sort of mapping our progress. I was thinking more in the context of like, we identified all the things you have to do to, that we would need to do to build sort of a Washington specific universal healthcare plan. And the FTAC has been really instrumental in thinking about sort of how they all go together. So I was thinking more in the concepts of like, we've built in sections, the blueprint of what we want. So there does seem to be, once we've gone through all the elements, the sort of how it all comes together piece, that the FTAC has the expertise to help us sort of pull together and see as a big functioning system, separate from like the work plan that's monitoring our work and that's showing the stage gates we're going through. So I was kind of in that same, Vicky, that blueprint, that space. So I don't know that helped, but I was sort of somewhere between the two of you, I think.
That's excellent. Maybe for our marching orders now, provide the commission's accepting of this, we will continue to maintain FTAC once we complete this work, and we can continue to bring this question back for additional feedback. And we'll also consider, based upon the comments, some ideas for demonstrating progress, maybe on our website, and come back maybe with some of those ideas, as well as maybe some different options of how we could roll up the work FTAC has done and make that easily accessible on our website into the public. And we can bring that information back at future commission meetings. So unless there's any questions or concerns, that is incredibly helpful feedback. Thank you. And I hope that the FTAC group is excited to learn that they'll be continuing. I hope this doesn't come as bad news. So
is there anything else we can volunteer them for while we're all here together? Welcome, new members, to your never-ending assignment.
So that was incredibly helpful. I am going to give it back to Vicky. And before I stop talking, I just want to thank everyone, and as well as the commission members, but the public, for really robust meeting and providing really helpful comments that we're certainly going to, think on and circulate internally. So thank you very much for the attendance today and the fantastic questions as well during Vishal's presentation. So thank you. And I will throw it back to Vicky.
Hey, well, thank you, everybody. Any last comments? We have a couple minutes, but also we could end a little early, and I don't think that would hurt anybody's feelings. All right, thank you so much for your time today. The recording and summary of this meeting will be posted shortly on the Healthcare Authority's website for the Commission. Our next meeting is Thursday, February 12th. Understanding that's during ledge session from 2 to 5 p.m. And we look forward to seeing you then. It is 4:52 and the meeting is adjourned. Thank you all. Have a
Happy
great
holidays all.
week.
Thank you so much,
Thank
everyone.
you. Happy holidays.
Happy holidays.
Happy holidays.